Good afternoon and welcome back to our first expert panel. We're delighted to be joined today by Christopher Wadsworth, Juan Valle, Maria Hawkins, Hassan Malik, and Shahid Khan. Christopher Wadsworth will be chairing today's session, and I would like to hand over to Christopher.
Thank you very much, Gary, and thank you to everyone who's already submitted some questions, and please do keep them coming so that we can feed them through to this expert panel. It's an absolute pleasure to be here this afternoon, and we've got a full 30 minutes to try and address as many questions as we can. So without any further ado, I'll go to the first question, which is directed to Maria. And Maria, in your opinion, are there any circumstances where it would be better for a cholangiocarcinoma patient to be offered radiotherapy over chemotherapy?
Sorry, Maria, you're muted at the moment.
Looks like we've got a bit of a sound issue there. So why don't I come to Juan for a question, then we'll come back to Maria. So Juan, this question relates to liquid biopsy or in fact a new tissue biopsy. So the question asks, should a new biopsy or liquid biopsy be done to see if the mutations have changed, which could potentially map out a different treatment plan? So I guess this is around whether we should be repeating the molecular analysis in the course of treatment and switching plans.
Yeah, thank you very much, Chris. This really picks up on the theme that we were discussing during the molecular session about trying to understand what's happening when a treatment no longer is effective and whether new mutations have developed. At the moment, this would be considered part of research in terms of understanding. We may not be able to have a new treatment available. And certainly at the moment, there aren't any licensed treatments available that we can then switch somebody over to. So I think we need to make sure that when we're asking for a new biopsy, it is made very clear that there isn't necessarily a treatment option at the end of it. And initially, it may be just about a scientific understanding of the disease, which is improved. But through doing this and doing it in patients globally, it's likely that we will improve the understanding and hopefully in time we'll actually get some treatments that will target specific new mutations that are then developing on treatment.
Thank you. Thanks, Juan. So next question, Maria. So Maria, are you online now? Can we hear you? Not yet, no. It sounds like we've probably got some microphone issues there, but I'll move on to a question for Hassan now. Hassan, surgery remains the only potential cure for cholangiocarcinoma in the UK, but we hear so many times that people are inoperable. Do you think that we are doing enough to, wherever possible, downstage patients and get them to the point of having surgery?
Thanks. I mean, I think I kind of dealt with this partially this morning. So inoperability is multifactorial. So there's the aspect where the patient's too frail for an operation, or they have multi-site metastatic disease where an operation would be inappropriate. And then there's the locally advanced T stage of the tumor where you'll have different opinions from different surgeons in terms of operability and the success of that operation. Certainly if surgery is response to that, then they should be rediscussed through the tumor board and surgery reconsidered, and that should be something that's should be considered. The thing that will change all of this is transplantation, because if we get to a position, perhaps as Nigel said, in 18 months, where transplantation is available, and assuming there's enough organs, then those patients who are deemed inoperable because of a locally advanced tumor, who would currently be sent down the palliative chemotherapy route, perhaps with an option of coming back to the tumor board, would then be referred to a transplant centre for assessment. So that would open up the curative intent options in addition to what we currently have. But I completely agree, if they come through our tumor board, it's important that they should be reassessed. The most important thing is that they get to that tumor board in the first place. So that decision has to be made, in the central MDT for your region. There's a lot of district hospitals that manage these patients. It's important that these patients are sent to the tertiary hepatobiliary MDT for a discussion, and then the management guided thereafter.
Thank you very much. So next question is for Juan. So it seems that often people are told that there is insufficient tissue for molecular profiling. How can people request or access a liquid biopsy? And I guess this is a further reflection on those questions earlier about equity of access to these sorts of technologies for testing and treatment.
Yeah, so at the moment, we need to be very clear that a liquid biopsy is not an absolute equivalent replacement for the tumor biopsy. So it does give us some information. It gives us some information on certain genes and DNA and RNA changes. But it's still in a process at the moment where we're learning about whether a liquid biopsy can be used as an alternative. Now, we know from other types of cancers, for example, lung cancer, that if you're looking at just one specific mutation, and you know that this is present in the blood and the tumor, then you can just use a liquid biopsy and rely and make all of your treatment decisions on the liquid biopsy. So with that caveat, I think at the moment we know that with liquid biopsies, it can give us some information. So for example, if we were to find an FGFR2 fusion in the liquid biopsy, then that's great because it allows us to target pemigatinib for management of that individual patient. But if we don't find something, it doesn't necessarily mean it's not present in the tumor. So we just need to be a little bit cautious about the caveats. So it's still in process of evaluation. In terms of accessibility, at the moment is mainly accessible through clinical trials or again, patients who may be insured or self-funded. But hopefully over the next few years, this will change. And you heard John Bridgewater talking earlier on about making this accessible to all patients across the NHS. This is obviously a UK answer.
Thanks, Juan. Maria, how are you doing down there?
I'm back, and I hope you can hear me now.
I can. Fantastic. So I'll just go over the question again to remind everyone. So in your opinion, are there any circumstances when it would be better for a cholangiocarcinoma patient to be offered radiotherapy rather than chemotherapy?
So it's a challenging question because I'm a radiotherapist and that's my job. So however, when we think about this disease and the fact that it can spread very quickly, radiotherapy is not a preferred treatment to start with in patients with locally advanced tumors. So in situation where surgery cannot be undertaken, chemotherapy is the standard of care. And as we've learned from the previous session, moving on to molecular treatment, it's something we should aspire to. And it pains me to say that, but one day we'll identify the patients who would benefit from radiotherapy treatments to perhaps be combined with systemic treatments. Thank you.
Thanks, Maria. So do please keep your questions coming in. I think we're going to have time for a few more. So the next question is Professor Khan. Shahid, Anne has asked a question that relates to the care her late husband received, but essentially she's asking whether we as a group of clinicians, as a community of clinicians, should be taking more interest in asking our patients questions about their lifestyle, dietary history and drug history, and feeding that into some central database that would allow us to work out some of the epidemiological factors or causative factors for cholangiocarcinoma. So I don't know if you could sort of address that, please.
Yeah, I think it's a really good point. These sorts of factors and questions should be part of general history taking, and certainly there is potential to build up a database of information. But simply noting down people's dietary habits or other lifestyle factors on its own can point to links, but is not really proof of anything unless you do a sort of proper study where you compare people who have had an illness to people who are otherwise very similar but don't have the illness, and then compare each of these different factors within a sort of statistically valid format. So it does end up leading to and if you do it that way, you can generate some potential hypotheses and some ideas. Simply anecdotally noting what people do or don't do doesn't really necessarily shine a great amount of focus light on particular causative factors. But these things should be detailed and they should be kept, because if we have enough data, one can do a proper statistical analysis and compare cases to those people who don't get the cancer but are otherwise similar in what's called sort of case control or case cohort studies. Yeah.
Thanks, Shahid. So Juan, I've got another question for you. I think that this is a good question. So what stage of treatment should a patient ask about molecular testing? So whereabouts in the sequence of standard of care should people be pushing for this?
Yeah, that's a very good question. Thanks, Chris, and the person who asked it. I think just to quickly clarify the stages. So we can talk about stages 1 to 4, but more importantly, early stage disease where you can have an operation, or advanced stage where obviously we're now talking about the systemic therapies. So as things currently stand in 2021, the treatments are available for patients with advanced disease. So it really is when patients have advanced disease that's not amenable to surgery, or they've had surgery and the cancer has come back. And that's the time when we as clinicians need to start thinking about molecular profiling. The current license is for patients who have already had chemotherapy. So of course that allows somebody to have time on chemotherapy and be tested and then go on to some treatment after that if they have an FGFR2 fusion, what we call second line or after second line. There are some clinical trials that are now looking at bringing it forward into first line, but that's currently outside of the license indication and it is part of research. Should you have molecular testing if you've had curative surgery, there's no evidence of any cancer? Not at the moment, as not changing the treatment. It would only be important to know that status if the cancer were to come back later on.
Mm-hmm. Thanks very much. And Juan, staying with you, a question's just come in related to this, and it's a sort of a logistical question. In the UK, can patients ask for molecular samples be taken from previous biopsy samples? So I guess is the material, if it's preserved in tissue blocks from previous analysis, is it accessible and useful for this molecular profiling, or does it have to be a fresh tissue sample?
No, it doesn't have to be a fresh tissue sample. So you can use what's called an archival biopsy, which is paraffin embedded. And that can be a biopsy that was taken 6 months ago, before, when the diagnosis was first made and people started chemotherapy, or it can even be a sample that was taken if patients did have surgery. That surgical sample can be used.
Great, thank you very much. That's a straightforward, positive answer. Another, sorry if I'm staying with you, keeping on the spot. Regarding targeted therapy, what is the current information about the effects of pazopanib on cholangiocarcinoma with FGFR2, FGFR3 amplification?
Okay, so pazopanib is a different compound. It's a multi-tyrosine kinase inhibitor, and what that means is that it targets a number of different pathways that can be abnormal in a cancer cell. Some of these pathways are involved with blood vessels, so vascular pathways, as well as FGFR2 and 3. Pazopanib is approved for certain types of cancers, not cholangiocarcinoma at the moment. And the FGFR2 amplification story is probably the strongest in gastric cancer, where it has been used. So I think this raises the question, what happens if you find these very infrequent molecular changes and there's potentially a treatment there? Might it work? I think we need to be very clear that in cholangiocarcinoma, we know that FGFR2 fusions, which is different to amplification, actually drive the cancer. So therefore, targeting that particular mutation is likely to be of benefit, as we've already seen. But sometimes what we identify are what are called passenger mutations. So just like a bus, rather than the driver, you've got a passenger. And sometimes targeting those passenger mutations won't work. So just because something works in one cancer doesn't necessarily mean it works in a different cancer. So we need to understand the biology of all the different cancers in their own right, and understand from clinical trials and the laboratory work whether treatments are likely to work or not.
Thank you. And one more for you, Juan. What are you telling your patients about the safety of having the COVID vaccine when they're having these drugs? And specifically, this questioner asks about pemigatinib. Sorry about my pronunciation of these new drugs.
Don't worry. With pemigatinib, there shouldn't be a problem with the current vaccines that we're using. And so we're advising our patients that they can have a treatment during it. The main concern with any treatments, including chemotherapy, is that if on treatment the blood counts are lower, then the vaccine just doesn't take very well. It's not necessarily harmful, but it just doesn't take very well. But thankfully, the blood counts on pemigatinib don't tend to take too much of a dip, so the vaccine can go ahead as planned.
Great, thank you. So we've got about 5 minutes left of the session, so we're going to try and go through a couple more questions. The next question I was going to ask is, oh, I've lost it now, bear with me for a moment. So there's a question here from Rachel. Do you see the requirement for biopsy a limiting factor if patients are going to require neoadjuvant therapy? Would you accept a radiological diagnosis, especially in the context of PSC? And I guess let's give Juan a rest. Hassan, would you like to respond to that? So do you see the requirement for a biopsy as a limiting factor for patients requiring neoadjuvant therapy in your MDT? Or would you accept a radiological diagnosis, particularly in PSC, to proceed with neoadjuvant chemo?
Yeah, so I think it's a slightly challenging issue, isn't it, getting tissue? You know this well yourself as a gastroenterologist. So if you look specifically with regards to surgery, ideally we would want to get tissue diagnosis to confirm malignancy, and we can increase our ability to get that by advanced endoscopic techniques like spyglass, etc., to get a biopsy rather than cytology. But even that said, there are patients that we would operate on in whom radiologically, clinically, there's a suspicion of cholangiocarcinoma, because alternative is active monitoring, and you may miss that window of opportunity to operate. And when we look back at our series, in only a handful of patients was the histology benign, and if it was benign, it was due to an underlying cholangiopathy. I suspect for oncologists, they would want tissue, almost certainly. I'd be surprised if they would treat a patient with chemotherapy or radiotherapy without tissue. In the PSC population, it's certainly more challenging. And going back to the data on liver transplantation, a lot of those patients were having a transplant in a PC pool of patients without ever having any evidence histologically, either prior to the transplant or after the transplant, of malignancy. And that potentially has an impact on the survival that you see after transplantation. But yes, but ideally a biopsy, but not always for surgery, but for other treatments, yes.
Thank you. And Juan, I see you're nodding. I guess a yes or no. Would you ever offer someone neoadjuvant chemotherapy without histological proven disease?
As a rule, no.
Okay, so I've been told we've got around 10 minutes left, so that's good. So we've got time for some more questions. So, question for Maria now, please. So, is stereotactic radiotherapy suitable for physically weak patients who are not suitable or fit for chemotherapy at present?
Oh, thank you very much for the question. And this is actually a very challenging question, because at the moment we don't have any evidence that stereotactic radiotherapy is actually beneficially long-term to patients. We know it can offer some local control, but we don't know whether it affects the overall course of the disease, or it should be given when at the end of treatment you might find out that there is disease elsewhere. So while technically, furthermore, radiotherapy is not without side effects. And perhaps in my talk, I was quite economical about discussing the implications of having the radiotherapy and what are the long-term and short-term side effects. So currently, radiotherapy, whether stereotactic or not, is not standard of care for cholangiocarcinoma in UK. And that's why we are undertaking this clinical trial for locally advanced disease, which are not operable, to compare 8 cycles of chemotherapy to 6 cycles of chemotherapy and additional stereotactic radiotherapy. I hope I answered the question.
So thanks, Maria. I think that's clear, and obviously a difficult situation for patients to find themselves in. Okay, thank you. And Juan, back to you. Again, question really about, I guess I'm trying to how to phrase it. So, in the course of some cholangiocarcinoma illness, can the mutations in the molecular profile change, and therefore can the vulnerabilities of the tumour change? And I guess the natural next question then is, should we be looking at tissue sampling from 6 months ago, or should we be doing sort of serial sampling to guide treatment as it goes on? I think that's the big question we're not able to answer yet, but I'm sure you're the man to give the best answer to that.
Yes, so I said that for the first round of molecular profiling, we can use an archival biopsy. But once we use a targeted therapy, what tends to happen is that if you're blocking off one target, then you may get either new mutations that are developing, or you get pathways that were previously silent, which then become more active to overcome the blockage, much like if you block the M1, all the A roads open up. And so the important thing then would be to rebiopsy if we are thinking about going on to another molecular targeted therapy. The issue is that we currently don't know what the next therapy should be. And this, of course, is now the next generation of clinical trials, is how to identify resistance and then how to actually deal with it. There has been a very nice paper in patients treated with an FGFR inhibitor showing that sometimes there's something called a gatekeeper mutation, because there seems to be a very specific new mutation that develops, a new fusion that develops, and it may be that that's one of the resistance mechanisms. Not all the FGFR inhibitors are the same. So molecularly, they are designed differently. They have slightly different mechanisms of action. So it may well be that we'll gradually learn that there is a sequence to the FGFR inhibitors, that you start off with one, and then you look for a new mutation developing or a new fusion developing, and then you switch to another one. So this is currently an area of active research. We don't have the answer yet, but that does rely on us and doing the updated new biopsies.
Okay, thank you very much. So we have to start winding the session up, and I've got a question which I've been asked to put to each of the panel in turn. So I'll read the question out first, and then we'll go around the virtual room. So what do you think is the most important thing we can do to improve the future care or treatment of those with cholangiocarcinoma? So what do you think is the most important thing we can do to improve the future care and treatment of those with cholangiocarcinoma? So Shahid, should we come to you first for your thoughts?
Well, prevention is better than cure. So preventing people getting cholangio in the first place. We're trying to get some funding to do a trial to see if aspirin prevents the risk of cholangiocarcinoma. But and trying to know what the risk factors are. But you know, if people get cholangiocarcinoma, then as with any cancer, the best chance is getting it early. So anything that leads to an earlier diagnosis, when people like Hassan can cure them, is to my mind the best thing. So prevent it whenever we can, and if we can't prevent, let's at least try and find it as early as possible. And whether that's developing biomarkers, elucidating risk factors, developing better screening tools, to me that would be important.
Thanks, Shahid. Hassan, what's your major thought or your biggest point for that?
No, I completely agree with Shahid. I mean, the difficulty we have in the UK is it still remains a relatively rare tumour. Often patients present late with non-specific symptoms. When you're jaundice, usually it's pretty far gone. I think, thinking outside the box, I think the biggest change to cholangiocarcinoma at a global level, coming back to the prevention issue, we do know that liver fluke is a risk factor. And I was interested to hear that there's now a potentially successful vaccine for malaria, which is being trialed. Now, if you can't change people's behavior to stop eating the raw fish, could something like a vaccination program or investigation of a vaccination program against the liver fluke make a difference? And that'll probably help patients in the Far East. It's not going to make much of a difference in the UK. I guess, picking up on some of the things which are here about, there was a question about different rates of surgery in the US versus the UK. I mean, the bottom line is a better integrated system wherein you've got centers of expertise where you get patients sent to as quickly as possible so they can optimize treatment, curative intent treatment if that's possible. Get tissue, because often if you try and get a biopsy, the first chance of getting a good biopsy is the first time it's done. If it's done in a local hospital and they miss that opportunity and they put a stent in, you may never get that biopsy. But getting the tissue, linking it to research and clinical trials, linking it to genomic assessment for all these novel agents, and yes, if surgery is an option, making sure you see the right person. That's for the UK, but at a global level, vaccination might be the answer.
Yeah, thank you. Maria, do you have any final thoughts?
I say 4 R's. Right patient, to have the right team for the right treatment at the right time.
That's wonderful. And as chairman of the session, I think that's a very pithy response. Thank you. And then Juan, finally with you, in the course of maybe 1 minute, can you just give us your thoughts on what would make the biggest difference? What would be the key thing to change in the management of our patients?
Okay, so biggest difference right now, I think building on international collaboration. We know these are rare cancers, and now, thankfully, we've got big international groups, European-wide global groups. So I think that is accelerating the development of understanding the biology of the cancer and treatments accordingly. And then for the future, actually going back to Shahid's question, I completely agree with prevention. We know that liver disease is the rising epidemic, and not just hepatocellular carcinoma, but also cholangiocarcinoma, and the risk factors of being overweight, fatty liver, etc., etc. And some of these are modifiable factors that, as a population, we can deal with.
Great, thank you very much. I think that's. Those are important points to end on, and thank you very much to the panel, Shahid, Juan, Hassan and Maria, and thank you to everybody who's contributed questions this afternoon. I think that was a really interesting session. Thank you very much. Gary. Can't hear you.
Thank you. Thanks, Chris.
Thank you, everyone. Much appreciated.